A very good morning to all of you all who are watching this webinar on this beautiful Sunday morning. On behalf of the SICOT India Executive Committee, may I now welcome you to yet another edition of the SICOT India Scholar webinar series. Arthritis is indeed a massive challenge to most of us who are in adult orthopedic practice. There are essentially two paths. The first path is of conservative management and rehabilitation, and the next path is about the various surgeries. However, in the last 10 years, a middle path has been found for those patients who either are not the best candidates for surgeries or in whom rehabilitation and medications have not worked. Today, we have a speaker, a pioneer of orthobiologics in India, and he's going to tell us about the biology behind orthobiologics. Our speaker today, Dr. Vijay Shetty, is the Vice President of the Indian Association of Sports Medicine. He's the General Secretary of the Indian Biologics Orthopedic Society. He's a consultant orthopedic surgeon, adult hip and knee specialist at the Hiranandani Hospital in Mumbai. As a career statement, he's a 3 times Limca Book of Record holder in total knee replacement surgery. He's the associate editor of the SICOT International Journal. He's an international examiner of SICOT examinations. He's a member of the editorial board of HIP International. It is the journal of the ISACA, Journal of Arthroscopy and Joint Replacement Surgery, and the Journal of Asian Journal of Arthroscopy. He's a full-time reviewer of the Journal of Bone and Joint Surgery, UK, HIP International Italy, British Journal of Sports Medicine, and Australian Journal of Sports Medicine, and the Indian Journal of Orthopedics. He's a regular faculty at the SICOT Education Day. He's a faculty of AO Trauma. He's a peer reviewer for the SICOT International Conference abstracts. He was the first one to introduce platelet-rich plasma therapy in India in the year 2009. He's a founder member of the Biological Orthopedic Society of the US, which was formed in Los Angeles in the year 2009. He has been nominated for the Best Scientific Paper at the SICOT International Orthopedic Conference in Morocco. He's a member of the British Business Group in India, a member of the Association of British Scholars in Mumbai, India. He's got several research publications in international journals, has lectured tremendously all across the world in international conferences, and has been a participant and demonstrator in live surgeries. He's a chairman and scientific committee member of various national and international conferences. So, without really putting in too much time, may I now introduce the speaker for today. Dr. Ashok Sham is going to help us conduct this webinar, and Dr. Vijay Shetty is going to be the speaker who is going to speak on the biology behind orthobiologics. I welcome Dr. Vijay Shetty.
Good morning. This is Dr. Vijay Shetty from Powai. I'm a consultant orthopedic surgeon in Dr. LH Hirandani Hospital. Thank you for coming on this session on orthobiologics, and I thank Dr. Ashok Sham and Swapnil Kenny for taking a lot of difficulties in arranging this webinar for you all, and thank you from the bottom of my heart. Before we start, this is a very interesting and, if you let me say, very spicy topic nowadays. And a few years ago, we published sort of a review on orthobiologics in the Indian Journal of Orthopedics, along with our colleagues from Chandigarh. So that was in the year 2014, about 4 years ago. You will find a lot of information in this article, and I think it is a free access paper. So I think orthobiologics, very interesting. Way back in 1992, this author, Leland Kaiser, actually predicted that in the future, a new branch of medicine will develop that attempts to change the course of chronic diseases, and in many instances will regenerate tired and failing organ systems. In other words, what he said at the time was that there will be a branch of medicine which can be regenerative, which can actually regenerate some tissues that are not healing. This is very, very important because why we should even think about orthobiologics. Orthobiologics is a branch of orthopedic medical practice where we try and do some lateral thinking. Now, if you really look at this slide, it's very interesting. I think there is no confusion at all when you look at this person's knees. Obviously, it's deformed, degenerated knees, and those are the X-rays, very bad. There is no confusion. There is no debate. This person needs definitely a knee replacement. There is no other option. Whereas when you look at some other conditions, even today, there are some clinical conditions which are a big, big challenge for us practicing orthopedic surgeons. And these are the conditions which have been around for many years. So that is something that has forced some of our orthopedic surgeons to do think out of the box, what is called lateral thinking, and we need to really look at some new ideas that and new treatment options that can help us in our clinical setting. So, if you really look at the definition of orthobiologics, it is basically a branch of orthopedics which includes biology and biochemistry to help enhance musculoskeletal tissue healing. In other words, it is something that will help us to regenerate the injured tissues or in some chronic conditions. And it is certainly one of the most exciting development in the last decade or so in modern orthopedics. There was a time when we started talking about this orthobiologics in orthopedic medical practice. The uh, auditorium would have 5 or 10 people, but these days, when there is an orthobiologic session in any meeting, you see quite a large number of young orthopedic surgeons attending the meeting. So if you really look at this option, it is one of those middle ground therapy, if you like, between the conservative side on one side, conservative therapy and invasive surgical option. So if you look at the whole spectrum of treatment of a particular condition, you will see that on one end of the spectrum, you have medications, you have physiotherapy and all that. On other end of the spectrum, you have the surgical options. So orthobiologics is probably perhaps fit somewhere in between. So when you look at orthobiologics per se, we at this day and age look at three different options or three different treatment modalities in orthopedics. There is viscosupplementation, and there is platelet-rich plasma, which is probably the most talked about option. And then there is bone marrow aspirate. So the whole thing, the three options come under the heading of orthobiologics. So I don't want to touch too much on visual supplementation. I think it's been there around for some time, and we all know that it is quite useful, especially in stage 1 and 2 of osteoarthritis. And obviously, this is a non-native form of cellular therapy, which means the product comes from outside. And I think there is no debate. There is, or if you ask me, uh, there are a large number of studies which support the use of physical supplementation, especially in knee osteoarthritis, in particular stage 1 and stage 2, and in young osteoarthritic knees. I want to touch on platelet-rich plasma, which is, I think, it should be the most important part of uh, today's discussion. So, platelet-rich plasma (PRP), which is a native form of therapy, it's your own blood, patient's own blood. This is the first autologous form, which means patient's own blood. Uh, and what does it do? It arguably stimulates a supraphysiological response. In other words, we like to call this biological augmentation, which means that we're trying to take or use our own healing potential to heal some conditions which have been difficult to treat otherwise. So again, I don't want to complicate this too much. I'll try to be as simple as possible because the basic science is quite complicated. But then when we talk about platelet-rich plasma, we think about these are some of the few things that come in at solution. We have the platelets, we have the growth factors, we have WBCs, RBCs, and off late there's been another kid in town which is called alpha 2 microglobulin. So that these are the components, these are the uh, products that are there in a solution that is called platelet-rich plasma. So when you think about platelets, we all know that if you do a complete blood count, the normal platelet count would be around 1.5, 150,000 to 300,000 microliter uh, per microliter. But when we talk about PRP, which is usually about 5 times more the baseline platelets. So why this is so important? I think it's very important because this is the story of platelets. Because whenever there is an injury, platelets are the first to arrive at the site of injury. So the potential to release growth factors are very high. That's why platelets are important. So when you look at the growth factor, that was the platelet side of the story. When you look at the growth factors, there are plenty of them. There are too many of them, and I would recommend you to read a paper from Jason Ragel from Stanford University, USA. He's done a lot of work on this, and when you look at all these growth factors, you get confused. It is very important to know that not all of them are helpful. So there are some growth factors which are pro-chondrogenic, which means they actually help healing tissues and cartilage. And there are some which are anti, which may not be good at this stage. We don't have too much information on this, but what is necessary to understand at this point is that PRP and the growth factors within the PRP, not all of them are good for the patient. So then comes the leukocyte bit. I think this is again, which is becoming very hot nowadays. And there was a time when PRP was being introduced in orthopedic clinical practice. Many people were not even talking about leukocyte. But I think in the last 5 years or so, there's been so much emphasis on the presence of leukocytes in the solution of PRP. So leukocytes, by default, they're always there in the PRP solution. So what happens is leukocytes promote inflammation, which is very important in certain conditions, and they also play a role as antibiotic type, antimicrobial role. This is important because you would have read about the use of PRP in cardiothoracic surgery when they open the chest wound, and many cardiothoracic surgeons nowadays apply PRP just to make sure that there is with the hope that you would prevent infection at the operation site. So most, as I mentioned earlier, most preparations of PRP are leukocyte rich by default. There are leukocytes, there are WBCs in a solution that is being prepared. But there are animal studies have shown that leukocyte rich PRP is bad for tendons. This is very important. Now I've just been saying that means in some conditions we may have to actually remove these white cells from the solution. So for that, you may need some special kits. So this is the current, at the moment, most physicians and surgeons who are engaged in in using PRP in their practice are talking about the leukocyte rich and leukocyte poor plasma. So if you ask me, at the moment there are two important types of PRP preparations for us, for a layman, to understand. So there is one leukocyte rich plasma PRP, and leukocyte. The other one is leukocyte poor PRP. So as I mentioned, we don't want, when it comes to a situation where you want to do a PRP injection into a joint, we don't want inflammation in the joint. We don't want to create a scenario where there is synovitis post injection. For that reason, we have to make sure that if you're injecting a joint, we have to make sure that it is a leukocyte poor PRP, so that there is no inflammation within the joint post inflammation. I think this message should be taken home very carefully and very, very important, because when you start PRP injection into various orthopedic conditions, if you don't understand what type of preparation is that, then you may actually harm the patient or make things worse. So I think in the last decade or so, I mean, in fact, in the last 5 years, we've had quite a large number of papers being published on orthobiologics in clinical practice, and more so on platelet-rich plasma. But there is still a lot of problems with the quality of research. The mainstream publicity of use of PRP in professional athletes is also being looked at by various scientists. What is happening is, I think, the marketing of PRP, especially in the Western world, is becoming very, very powerful, and especially because it's being used in elite athletes. And so I think that is also pushing the use of PRP in the clinical setting. I think it's very important to understand that we still need larger clinical trials to understand the mechanism and efficacy of this treatment, and its indication specific. I think it's very, very important. If I'm trying to use a PRP for a tendon problem or a soft tissue problem, I should be looking at PRP rich plasma, because we want to get things healed uh, uh, with some inflammation. Whereas if it's a joint scenario, then I think we should be looking at PRP poor plasma. The third generation of orthobiologics, we finished with the visco supplementation, and we have talked about the platelet-rich plasma. The third generation of PRP, which is again being used in cartilage degeneration, is called bone marrow aspiration. Um, uh, just forgetting what C stands for. Okay, BMAC induces differentiation or proliferation of resident stem cells, and this has chondrogenic potential. And again, when you talk about BMAC, which is again being used widely nowadays, there is paucity of high quality research, and we actually need larger clinical trials and physician collaboration required to further expand this third generation of biologics. Let me tell you, there are a lot of people using BMAC for cartilage, focal cartilage defects, and results are encouraging. And at the moment, I can tell you that certainly there is no harm in using this. We don't know how useful this has been on the long run. So if we are looking at the use of orthobiologics in orthopedic clinical practice, we should be looking at use on bones, on tendons, and cartilage. As I mentioned, when I started PRP in my practice, I was not even sure whether it was leukocyte rich or poor. But again, there were people who would actually use more platelets in their preparation. So, and if you go into the industry now, I think there are a number of companies making PRP kits. So each application or each preparation is different. So that's why it has been difficult for us to actually do studies on PRP as a preparation. So there are different formulations which are being used worldwide. The VMAC injection for tissue engineering is also taking shape now, and its use in cartilage regeneration is becoming quite popular. This is what we do in severe condyle defects, in multiple condyle defects. There are people who do arthroscopic application of BMAC. In fact, you can make BMAC gel, which is quite stable even for undersurface of the patella, and a lot of people do this arthroscopically. But in a situation like this, where you have severe condyle defects in multiple areas, there is no harm in opening the joint and filling the defects. So this is a big marketplace. I think in the last 7-8 years, Orthobiologics has become a very popular destination for young orthopedic surgeons, especially. And you've heard about a lot of institutions abroad. People are making commercial gels and so many things. So it is a big business. Now this is uh, supposed to reach over $500 million by this year end, the whole business of orthobiologics. So I think there is a lot of potential in orthobiologics. The big question at the moment is, am I going to recommend uh, this to my patients? I think it is very important with the background that you know that potentially there is no harm in using orthobiologics, especially platelet-rich plasma. But at the same time, for an anxious patient, I think it's very important that you sit with him or her and take them through the whole process of preparations and the short-term results and the long-term results of using this, what can go, or what may happen in 3 months or 6 months, and there is a chance that it may not even work. I think it's very important that you tell them, and if they give their consent, I think you should go for it, because definitely this is a midway approach between the conservative therapy and surgical option. In my own clinical practice, I have been using PRP for Achilles tendon and plantar fasciitis. We have published some of our results, but I'm quite encouraged by my results with plantar fasciitis. It's been very encouraging. So I'm using PRP for plantar fasciitis largely, especially the ones which are recalcitrant. Recalcitrant plantar fasciitis is the one which is probably the right indication before going under the knife. My experience with the osteoarthritis is limited. Uh, So I think the important message here is a surgeon who wants to take this on board in its practice should know how it works and does it work at all, and what preparation is necessary for that particular indication. Is it safe? It's more important to know whether it's safe or not. But there is enough evidence that use of PRP and BMAC is safe, and I can tell you that the National Institute of Clinical Excellence in the UK has taken orthobiologics on board for clinical applications, which means that it is safe, the government has approved. And is it cost effective? This is a question that we must ask in our country. Now, let's imagine a scenario where a person comes with recalcitrant plantar fasciitis. You offer steroid injection and you do it well. They get good results and very nice, and it doesn't cost much. But if I'm doing a PRP in my setup, I have a PRP room in our hospital, and the whole thing costs around 30,000 rupees per injection. So then comes a question: patient who is sitting in front of you, how would you tell them that this is almost 5-6 times more than the injection with steroids? So there are a lot of things about this, but is it cost effective? If you ask me, I have done over 200 PRP injections for plantar fasciitis in my setup in the last 7-8 years, and I'm thoroughly encouraged, especially for the recalcitrant ones. So at the moment, we have more questions than answers on the use of orthobiologics in clinical practice. But however, I think safety is done. Efficacy is still being debated. Cost effectiveness, where there is national insurance, I think it's okay. But in our private setup here in India, we'll have to really discuss that with the patient. Thank you very much for your attention. I encourage you to attend this meeting. This is next one in Chennai. This is the second annual meeting of Indian Biologics Orthopedic Society. A lot of questions will be answered around there, and there'll be many experts coming from all over the world. It will be a good opportunity to meet people and network. Thank you for your attention, and sorry to bother you on a Sunday. Thank you.
I thank Dr. Vijay Shetty for a wonderful lecture and webinar. It was indeed enlightening experience for me as well as I'm certain for most of y'all. And now we will take a few questions before we end this webinar. I thank all of you for participating in this webinar. And if there are any other questions which you have, which may come after this webinar, you can write to us at sicotindiascholar@gmail.com. Thank you very much and have a wonderful Sunday.